If we talk about avoiding complications at Caesarean section, the first step in avoiding all complications in obstetrics is avoiding unintended pregnancies. And I just want to emphasize the importance of contraception. We know in the Eastern Cape, certainly at Frere and CMH, about 4,000 women a year terminate their pregnancies. And of those who have babies, 2/3 have unintended pregnancies. So if we can reduce unintended pregnancies, we can reduce a lot of the mortality and morbidity from obstetrics. And our best bet is popularizing and using the copper. So we need to do everything we can to ensure that all women have access to contraception that they want. The next step is to avoid unnecessary Caesarean sections. These days, many of the Caesarean sections done are quite unnecessary, mainly because doctors are anxious about slight, shall we say, variations in the CTG pattern, and they're worried about fetal distress. Remember that CTGs hopelessly overdiagnose problems, and that's why WHO actually advised that in low-risk women we should not use CTGs at all. They do more harm than good. But today we'll emphasize technique, Caesarean section technique, and I'm going to take you through some aspects of the technique. Pre-operatively, make sure you assess the patient well. Take time to optimize the mother's condition. You know, if someone comes in ill, don't rush to do a Caesar. Spend your time, assess her carefully, make sure she's as fit as she can be before she goes to theatre. Have blood available if she's high risk. For an elective Caesar, never do it before 39 weeks. We know that babies are not mature before 39 weeks. If you're in doubt about the gestation, rather wait for labor and then do the Caesarean section. Don't starve women unnecessarily. Women can eat up until 6 hours pre-op and drink clear fluids until 2 hours pre-op to avoid dehydration. Have a catheter in, and if the woman's in labor, give a beta stimulant such as salbutamol to relax the uterus while waiting for surgery. The other thing to remember is when you have a critically ill patient, it's very difficult to decide at what point to do the Caesar. Ideally, you should try and optimize the patient's condition first, because going to theatre is dangerous. However, if you have someone who's deteriorating despite all the possible best treatment, then you need to deliver as part of your treatment, because the pregnancy is a huge drain on the oxygen and the mother's resources. And if you can remove the pregnancy, her chance of recovering is improved. If your patient arrests when she's in the 3rd trimester, if you haven't brought her around, if you don't have circulation within 4 minutes, you have to immediately remove the baby. You have to be really, even if you've never done it before, you've got to be prepared to do that. And all you need is sterile gloves, a scalpel, and some cleaning fluid. You just pour cleaning fluid over the abdomen, do a midline incision, a classical incision, remove the baby, and then just hold the uterus, compress the uterus manually. And what's very useful now, your hands are in the abdomen, you can actually compress the aorta as well, and that will assist with the resuscitation. I have a checklist when I get to theatre, and that is, I've changed it over the years. It's now CHILL, C-H-I-L-L, because often you haven't seen the patient before. You may be in theatre and the patient is sent as an emergency, and you want to check that everything's been done. So you check that she's been counseled for contraception, particularly tubal ligation and IUD insertion. H is the heart. Is the fetal heartbeat still present, particularly if you're doing the Caesar for fetal distress? If the baby's died on the way to theatre, the last thing you want to do is a Caesar. I is the indication still valid. If she was progressing poorly, do a PV on the table to check she hasn't perhaps quickly progressed. If it was a breach, check it's still a breach because baby's turn. Then L, first L is live of the baby. You want to know which side the baby's back is on, so that when it comes to delivering the head, you can rotate the head to deliver occipito-anterior and avoid tears in the uterus. And then the other L is a good line, at least an 18-gauge secure venous access, so that if you have problems, collapse or bleeding, you're able to give fluids fast. And then, of course, we always use a routine surgical checklist. Identify the patient, everyone in theatre introduces themselves, says what their roles are, and the planned operation is described. Anesthesia, generally the spinal is safest, using a fine needle, never a 22 gauge, must be smaller than a 22 gauge. Otherwise, you'll have really bad complications with spinal headaches. There's a big problem with platelets because the anaesthetists advise not to do a spinal with platelets below 50. But to be honest, even below 50, a spinal with a fine needle is much safer than a GA. And in fact, all the data we have about hemorrhage is based on epidurals with huge needles, 16 or 18 gauge needles. And to my knowledge, there's never been a case of severe bleeding from the spinal with a 23 or smaller gauge needle. So the other thing is you should, even if you're doing spinals, be prepared to do a GA. If you're not confident to do a GA and your spinal fails, if you haven't actually started the surgery, don't start. It's better to either repeat the spinal or abandon and refer elsewhere than to go on to a GA if you're not really confident to be able to do that. The abdominal incision, we now use Joel Cohen transverse blunt dissection. This is by far the best for the mother, even if she's had a previous vertical incision. If we're unsure what will be found or what to expect, then we should do a midline vertical incision because that gives us unlimited access. So for example, if you think it may be an extrauterine pregnancy, or you think there may be, if there's a placenta previa, which may be a creta, much rather do a vertical incision. It's not a good incision in terms of repair and recovery, but it's the safest incision in terms of immediate operative access. Parietal peritoneum, we open the blunt fingertip high up after feeling around for adhesions such as bladder and bowel. And if we have adhesions between the uterus and abdominal wall, try to feel your way around the adhesions with a finger. Make sure there's no bladder or bowel nearby, then clamp the adhesions and cut, leaving the clamp on the uterine side. It's always the uterine side that bleeds. The abdominal wall side will seldom bleed. And you can just leave that clamp and tie it later. And as you know, we stretch the abdominal wound to be sure it's big enough for the baby. Traditionally, we open the loose peritoneum over the lower segment and separate the bladder and ureters from the uterus, pushing down and laterally. Some studies suggest this may not be necessary, but we're not really sure if they are big enough to be sure that we won't occasionally have bladder problems. Okay, so let's go back. So we open the uterus transversely for a few centimeters, just till we see the shiny peritoneum bulging. Then open it in a chordate cephalad direction. So we've all got used to tearing from side to side, but you actually tear up and down, and that opens the uterus safely. Make sure the opening is big enough for the baby. And then the critical thing is if the mother is in advanced labor and the head is down in the pelvis, firstly, have salbutamol ready, drawn up, and if there's difficulty delivering the baby, immediately give IV salbutamol. It relaxes the uterus and makes everything much easier. Then the next critical thing is if you're on the patient's right, the natural tendency is to put your right hand in, and that's wrong. Put your left hand in and pass your left hand down between the symphysis and the baby's head, and steadily with your hand over the baby's head, pull the baby's head up until it's above the level of the uterine incision. Never try to deliver the baby's head while it is not yet above the level of the incision. If you can't get it above the level of the incision, much better to leave the head, quickly put a hand into the upper abdomen on the opposite side of the baby's back, find a foot, make sure it is a foot, and then pull the foot out and do a breech extraction, and the head will follow easily. Much safer than trying to deliver a head which won't come up out of the pelvis. If you do get the head above the uterine incision, then with your left hand, which is still in the uterus, rotate the head to the occipital anterior. That's why you want to know which side the back is on, so you can rotate the head. Once you're ready to deliver the head, you then use the back of the finger. So you put your right hand with the palm facing you and use the back of the fingertips to push the lower uterine segment backwards into the pelvis behind the baby's head. Your right hand is not inside the uterus. It's outside the uterus, but pushing the lower part of the wound backwards behind the baby's head. You then remove your left hand out of the uterus and give fundal pressure so that when the baby's head comes through the uterine incision, it's only the head. You don't have either hand in the uterus. And you use the fingertips of your two hands to just sort of stretch the incision around the baby's head with your fingertips while delivering with fundal pressure. And usually the baby's head will pop out easily. If it doesn't, then much better to put forceps onto the head and deliver it, then never use your hands to try and pull the baby's head out, because your fingers take up a lot of space. And if your hands are in the uterus pulling out the head, you will invariably get tears of the uterus, and that's where you run into all the problems of bleeding. Okay, great. So when the baby's head is low in the pelvis, use your left hand to go between the symphysis pubis down into the pelvis inside the uterus. Cup your hand over the baby's head, bring it up to above the level of the incision. If you can't do that, leave the head. Put your right hand up into the upper uterus on the side opposite the bag, grab a foot, make sure it is a foot, pull it out, and then the breech will follow and the head will follow last. If you do get the head above the level of the uterine incision, hold it there with your left hand, then use your right hand with the palm facing you, and with the back of the fingers, push the lower segment of the uterus below the incision backwards in the pelvis so that it is now lying behind the baby's head. You can then remove your left hand out of the uterus and then give fundal pressure and use the fingertips of both hands just to sort of stretch the wound edges around the baby's head. The right hand actually guides the head out of the pelvis, but it's not guiding the head out of the uterus. You're sort of pushing the wound of the uterus around the baby's head rather than pulling the baby's head out of the uterus. So the principle is never use your hands to pull the baby's head out. Use your hands must be outside the uterus, so stretch the incision around the baby's head. And if you don't manage with that method, rather put on forceps. Even if you don't get them on perfectly, the forceps don't take up space and will usually get the head out very quickly and easily.
Sure.
Okay.
What would you say, having obviously watched many Caesars and many junior doctors do Caesars, what would you say are some of the main shortcomings or main mistakes that surgeons make at this point in the operation?
Okay, first one, not a big enough abdominal incision. Second one, not a big enough uterine incision, particularly with previous Caesars when there's a lot of fibrosis around. But the main one is putting the right hand into the uterus and trying to deliver the head. Because as you do that, your right hand, as you lift the head up, tends to sort of use the lower uterine segment as a fulcrum. And that motion tends to cause tears which go down into the lower segment, can even go right down into the vagina and be an absolute nightmare. So that's the biggest mistake that is made, using the right hand to try and deliver the baby's head from the uterus. And, you know, sometimes you can look for an ear that can help you, but in the end, you just try and judge where the head is, and if it's not coming out easily, try and feel for the back, feel the back of the neck, and then just with your fingertips, sort of pull the occiput around anteriorly and see if you can get the occiput appearing in your wound, particularly if the woman's been in labor and there's been quite a lot of molding, because then you have a sort of a long molded head. And if you can get the occiput out, then the rest of the head follows easily. But if you're trying to deliver the head sort of as a brow or as an unflexed head, then it's much more difficult.
Yeah. And would you say, Prof, would you recommend surgeons having obstetric forceps, Wrigley's forceps open routinely, or is that something you would recommend just having in theatre in all cases?
Yes, it must always be in the theatre. Some Caesar trays have the forceps on the tray, but if not just have your sterile set of forceps always in theatre. It really makes such a difference. And then if you're struggling with the head, just try and feel for the sagittal suture, even if you're not sure which is the occiput and which is the sinciput. Try and just get the sagittal suture sort of centrally in your field, and slip the forceps blades one on each side of the sagittal suture, lock them, and usually the head will come out quite easily. Sometimes you find it wasn't put on well, but you still get the baby's head out quite quickly and easily.
Yeah, sure. And then maybe lastly, would you go through the internal pedalic version just one more time for the deeply impacted head?
Yes. So if the head won't come out of the pelvis, quickly put your right hand up into the upper segment on the side opposite to the back. Feel for a foot and make sure it's a foot by feeling the heel. The heel has a characteristic feel. You can't always distinguish toes from fingers, but the heel feels characteristic. Once you're sure it's the foot, just quickly bring it down through your wound. Sometimes you can sort of push the baby a little bit out of the way with your left hand, but as long as you, and you know, you can put quite firm pressure on the leg. Sometimes you even need a gauze swab to hold on to the foot because it's very slippery. Hold it with a swab and just firmly pull it down, not fast, but steadily and decisively. And if you just keep pulling, almost always the breech will follow the foot, and once, of course, the breech is out, it's easy, the head will follow.
Okay. Awesome.
Okay. So I'll move to cord clamping. Remember, in all obstetrics, delay the cord clamping for 60 seconds at least to allow placental transfusion, which is essential for the baby's health. We get a lot of anemia in babies who have early cord clamping. And what I do, because 60 seconds is a tremendously long time to wait, so I spend that time drying the baby, and then I chat to the mother. I drop the screen, ask the anesthetist to drop the screen. Then, you know, even with the cord still attached, I take the baby across and show the mother, and show whether it's a boy or girl, and chat to the mother a bit. And then I look at the clock, it's usually only 30, but anyway, keep the baby dry. And then after 60 seconds, clamp the cord, ask the midwife to take the baby back to the mother to show her. And then we use, the other thing is delayed cord clamping, whether it's a Caesar or a vaginal birth, is even more important with preterm births, because quick clamping increases the risk of intraventricular hemorrhage and death in those babies, in preterm babies. So you actually reduce mortality in preterm babies by delaying cord clamping. And then, of course, always keep the baby warm and dry, particularly the small baby. I think I might have missed one. Let's just see. Yeah, placenta just deliver with cord traction, not manual removal. You get more bleeding and sepsis if you do a manual removal. Twist and clamp the membranes, try and pull them out easily. check with your hand that the uterus is emptied. Don't swab it out unless there are membranes you need to remove. Swabbing out the uterus increases bleeding and sepsis. A lot of these things are a bit counterintuitive. We love doing them, but studies have shown that swabbing isn't a good thing. So just put your hand up into the upper segment, and if it feels empty, no membranes, that's fine. If membranes are retained, they're more usually in the lower segment, and then you can just use a swab to sort of pull them out or pick them up with forceps and get them out. Then closing the uterus, quickly look for active bleeding and clamp with green armitage forceps if there are. If there are no bleeders, I usually just put one green armitage on the middle of the lower segment. You know, having lots of green armitages, people put them on the corners, really they just get in your way. And only if there are big bleeders, put the green armitages on quickly to stop the bleeding. Once you've identified the lower segment edge and got your green armitage, then put your bladder retractor in. Most junior doctors remove the uterus from the abdomen. That's fine. It does cause more nausea for the mother, but it certainly gives you, I think, more confidence. You can see everything more clearly. So do feel free. I never remove it, but do feel free to remove it if you find that easier. And we close the uterus usually with polyglycolic acid, such as Vicryl, with an O1, a large round body needle, preferably a blunt needle is the safest if you can get hold of that. Then figure of 8. Okay, now I'm going to talk about closing the uterine incision. The most important thing is the angles, and whether you're going to use continuous sutures, 1 layer or 2 layers, or interrupted sutures, I'd recommend to start with a good figure of 8 at each angle. What I find the easiest is to take the lower and then the upper incision edge about 1 to 2 centimeters, mount your needle. You are maybe losing connection. Remount your needle. Then hold the stitch you've put through the uterus with your left hand and pull it, if it's the far angle, towards yourself so that you can see the angle now very clearly, and put your second suture just lateral to the angle, and then tie that as a figure of 8. After then you do both the angles like that. For these sutures in between, we are putting the needle below the uterus, then bring it out over there above the incision, then in there, and then cross behind and out here, and then tie. So it's a figure of 8, but it crosses inside the uterus and ties straight over the outside. Okay, so if there's bleeding, the best is to use figure of 8 sutures to control the bleeding. And usually the bleeding is from the lower segment. And so what I do is, instead of putting the figure of 8 sort of vertically across, in other words, at right angles to the uterine incision, you put your sutures parallel to the incision. So you put a nice deep suture in the lower segment, parallel to the incision, going in on one side of where it's bleeding and out on the other side. And then you do the next part of your figure of 8 above the incision. And when you tie that, it usually stops the bleeding very effectively. So it's, again, a bit counterintuitive. So your figure of 8 is not sort of closing the incision, but you're rather putting a good deep suture parallel to your incision in the lower, below the incision, and that's what picks up the bleeders. And then you just complete the figure of 8 above with a catching tissue above the incision and tie it very tightly. I'm going to move on. IUD insertion, you just need to be sure it's put right up at the fundus and left at the fundus. You can either hold it in your fingertips and put it up at the fundus, or you can hold it with a ring forceps, or you can use the straw without the plunger to guide it right up to the fundus and then just gently pull out the straw. And then the threads of the IUD, you push down towards the cervix. They usually don't reach the cervix if it's a copper T. And then when you're closing, you just be careful not to catch the strings of the IUD. If you do a bilateral tubal ligation, the Pomeroy type is fine. Be sure you identify the tube by following it all the way to the fimbriae. You use a catgut suture if you have it, otherwise often we have only PGA and have to use that. Some people think a salpingectomy is more effective than a tubal ligation just because it's irreversible, but that doesn't follow. The fact that it's irreversible doesn't mean it has a lower failure rate. The failure rate is exactly the same, 0.5 to 1%. So I prefer to do a tubal ligation, saving the fibria in case the woman might come back requesting a reversal. The abdominal closure, we usually close the peritoneum. We don't close the peritoneum. We can use a PGA 001 for the transverse sheath, but if we've done a vertical sheath, probably safer to use something stronger such as PDS. It's recommended to close the subcutaneous tissues only if they're more than 2 centimeters in depth. To be honest, I seldom close that. And for the skin, we can use either subcutaneous sutures or interrupted sutures. Studies using staples have shown worse outcome with staples than with suturing. We then just express the uterus and swab the vagina and check the urine. Post-op, very important to observe the patient carefully, particularly for signs of bleeding. Remember, she may bleed vaginally or she may bleed into the abdomen. So we need to monitor her pulse and blood pressure carefully. And if in doubt, take any signs of bleeding seriously. We give a good analgesia, DVT prophylaxis only if she's high risk. Free fluids start immediately. There's no need in a routine Caesar to starve the patient. Start free fluids early. Mobilize her as soon as you can. Get the catheter out as quickly as you can. Some people suggest take it out immediately. We usually leave it just until the patient is out of bed, which should be within about 8 hours. And we don't give post-op antibiotics unless she's very high risk. So we just use the single dose of antibiotics pre-op for prophylaxis. Morbid obesity, as you know, is a problem. Only if you have one of those women who, when they stand, their penis sort of hangs right down almost to their knees, should you then consider doing what we call a suprapenis incision. And what you do there is when the mother's on the table, you don't lift the penis, you just let it lie in its sort of neutral position. You palpate for the symphysis pubis, and you can usually feel it. There's usually a kind of a window around the umbilicus where you can feel the symphysis pubis. And then you just make a transverse skin incision 3 centimeters above the level of the symphysis pubis. You usually find that that incision is actually above the umbilicus, or it may be just below the umbilicus. And then you just go straight down through the fat until you get to the sheath. And then once you're on the sheath, you clear the sheath. Again, use your symphysis as a landmark. And then you go in just as you would for any other transverse incision. And you don't have those problems of going through an area of macerated sort of skin where the penis has been hanging, and the wound healing is usually much better with that so-called suprapenis incision. I just want to talk a little bit about massive hemorrhage, because that is what scares everyone. And you need to keep calm and move quickly. So don't panic, be very calm, but also don't freeze, don't delay. When there's a lot of bleeding, you need to stop the bleeding. And the one thing that everyone always forgets about is you can immediately ask your assistant to compress the aorta, to completely block the aorta, and that will immediately reduce the bleeding. And this, if sometimes it's possible with a thumb, if the assistant's thumb is not strong enough, they can put their whole hand into the abdomen and use the sort of heel of their hand against the spine, slightly on the left side of the spine, just above the sacrum. So just above the sacral promontory, to completely compress the aorta. And that you can do for quite a long, at least 10, 15, 20 minutes even. You will not cause any sort of avascular necrosis, and that gives you a breathing space to control the bleeding. You look for where the bleeding is, and if possible, put clamps. If it's on the uterus, green armitage clamps. If it's outside the uterus, artery forceps, but just try and clamp the bleeding wherever you see it. If you can't get clamps on, then use the general surgical pressure principle of firm pressure on any bleeding sites, and just hold and just keep pressing while the anesthetist resuscitates the patient, calls for blood. But you really want to conserve blood. You want to keep the bleeding clamped or pressure on it, plus your aortic compression to minimize the bleeding. If you're struggling and you're not able to control the bleeding, the next step is a uterine tourniquet. And it's a very, very simple thing to do. So you just get you place one green armitage on the lower uterine segment on your wound edge. Then you take a Foley catheter, not too thin, at least a 12 or 16 or even a 20 size Foley catheter, and you just loop it right over the fundus of the uterus, and then put it all the way down into the pelvis behind the uterus, and then pull it across in front of the uterus over the lower segment as low down as you can, below the green armitage that is holding the lower segment clamp. You can put a single throw in it, or even just cross the edges and put it as tightly as you can. Really stretch it tightly, and then your assistant uses a small artery forceps to clamp the Foley at the point where it crosses. And if it's pulled tightly enough, that will stop all bleeding from the uterus, because you've actually got your ovarian and your uterine arteries all within that tourniquet. So if you've pulled it tightly, it should stop all bleeding. And then you can relax. You can, as I said, put up more lines, resuscitate the patient, start looking for your bleeders, putting clamps on them, suturing your bleeders, but you're not sort of under a pool of blood that you can't even suck fast enough to get out of your sight. Okay, so please remember the two real sort of life-saving first aid measures are aortic compression and putting a uterine tourniquet as low down on the uterus as you can to stop all the bleeding. If you've put the tourniquet on and you feel you're not going to be able to cope with the surgical problem, you can leave that tourniquet on, close up the abdomen, and get the patient to another center as quickly as possible where they can do the hysterectomy or whatever is needed to stop the bleeding.
Yeah, I just got one question from the panel, Prof, just with regards to uterine closure. When using a continuous suture technique, I know there's been a lot of evidence on single versus double layer closure and locked versus unlocked suture technique when doing a continuous layer. What are your thoughts on what the evidence says for that?
Okay, so the most recent evidence is not to lock the sutures. They're just an ordinary running suture gives you the best closure, and that was both based on sort of post-op ultrasound studies looking for gaps in the closure. Be very careful when you place your sutures to take a good bite of muscle starting quite far away from the edge of the wound, but trying to come obliquely through the muscle and miss the endometrium. You don't want to pull endometrium up into your wound. And then once you've done that, a second layer is better because there's evidence that the risk of rupture at the next pregnancy is less if you put 2 layers than if you put 1 layer. So I would say 2 layers of ordinary continuous running sutures without locking.
And you did mention that using the figure of 8 technique precludes the need for a second layer.
Yes, yes. With a figure of 8, you get a really strong, sort of thick closure of the uterus, and there's no need for a second layer. Although, let me just qualify that by saying that that is based on animal evidence. We don't have clinical evidence in humans. So I would always qualify that. But just to say that, for however many years, 45 years, I've used nothing but the interrupted sutures. And they seem to me to give a better hemostatic effect. One seldom has to put in extra sutures. And once you're used to doing them, they go pretty quickly. You do have to be good at tying knots because your knots must be tight. They mustn't slip after the first throw so that the suture ends up being loose.
So when you're using that figure of 8 technique, besides the corner stitches, how many figure of 8s would you, on average, use to close a uterus?
Yeah, I usually manage with 2, seldom more than 3.
Okay, wow, that must be fast.
Yeah, it doesn't take too long. Once you get used to it, it's really. And here in Botswana, I've actually been teaching all the registrars here, and they've really taken to it. They quite like it, so it's becoming the method used here.
Prof, could you talk to us about B-lynches and indications for B-lynches?
Yes. Because
I think it is something that is maybe underutilized in the management of PPH. I'm not sure. I use them a lot, but I'm not sure what your experience has been with them.
Yeah. They're well accepted as a good way of controlling an atonic uterus. Whether it was following Caesarian section or following a vaginal delivery, most people forget how to do them. You need to have one of those pictures up in theatre. But to just braces, if you imagine a person having braces going over their shoulders, and the tricks are, first of all, you need quite a strong suture, something like a number 1 PGA suture, with quite a big needle. Then you start in the lower segment, below your uterine incision, if it's a Caesarian section. So you go into the lower segment, below your incision, you come back out above your incision, then you loop it over the one shoulder, then you go behind the uterus and you bring it from behind the uterus into the uterine cavity on the same side. So let's say you've done it on the patient's left side, all of that has been on the left side. Then from inside the uterus, you go back out of the uterus to behind the uterus. Then you bring it over the other shoulder, over the other side of the uterus. Then you go into the uterus above your incision and then back out of the uterus below the incision. Then you tie your first throw and you start pulling it tight. But the important point now is your assistant must hold the uterus in both hands and squeeze it firmly. And as the assistant squeezes the uterus, you just steadily pull that B-lynch suture tighter and tighter and tighter. And you must spend some time doing that. So that with the continuous squeezing and the pulling, you're really getting a good compression on the whole uterus. And then once you're sure you've done that, again, be careful that when you tie your knot, it doesn't slip and you have a good compression. There are other, perhaps simpler sutures. The one thing is if there's bleeding from the placental site, and if you can see it, if you can see the placental site, particularly with a placenta previa, then you actually put figure of eights wherever you see bleeding, and you can put 10 or 20, it doesn't matter how many you put, you just keep putting figure of eights. So wherever you see bleeding on the placental site from inside the uterus, you just keep putting figure of eights, and sooner or later the bleeding stops. If you have bleeding from the fundus, and it's a sort of a floppy fundus that's not contracting, you can also do what we call square sutures. So you imagine a big square, perhaps a 5 centimeter sided square, and you've just gone in at each corner. So from the front to the back at one corner, back to the front at the next corner, front to the back at the next corner, back to the front at the next. Tie that tightly. And that sort of compresses the anterior and the posterior uterine walls together. You obviously use an absorbable suture so that afterwards it will absorb and the uterus will open up again. The other thing to remember is devascularization sutures. So you can tie the uterine arteries, and what you do there is just sort of open the peritoneum of the lower segment below your uterine incision, and then so that you can sort of see the muscle of the uterus, and you can often palpate the uterine artery there, which is coming up from below on the lateral edge of the uterus, and then you carefully put a suture around the uterus and then coming in from behind to the front, and you tie that firmly, and that will occlude that uterine artery. Do it on both sides. If those are still bleeding, you then tie off the ovarian arteries medial to the ovaries. So you'll see from the ovaries, there's a sort of a ligament going towards the corner of the uterus, and it's behind the tube. And you again take a bite there of the uterine muscle, being careful not to close the tube, but including the blood supply, which is coming from the ovary to the uterus. And you tie both those sides, and that'll often stop the bleeding. Interestingly, although theoretically you've tied off the blood supply, there's always a collateral supply, and the uterus doesn't become atrophic.